Hello, students. This is Dr. Johnson, and welcome to Paying for Healthcare in America and the Rising Costs and Challenges. So this will be in the third exam, and unfortunately, we couldn't do it in class, but I welcome you. If you have any questions after this, please email me. I will answer every single question. Okay, so for the objectives for this class, we're going to look at how do you analyze some of the major factors that influence healthcare, and how do you integrate that knowledge of that healthcare resources and financing into your practice. And we're going to look at the relationship between contemporary economic issues and trends of what's going on with the healthcare industry and in the arena and what's happening in the federal government. And of course, discuss the Affordable Care or Obamacare, as everybody knows it. So we're going to look at those. And again, if you have any questions, please reach out to me. The key terms are listed in front of the textbook. Please take a quick look at it. I'm not going to read it to you, but it's very important that you know these key terms. Okay, so the purpose of this lecture actually is to look at some of the economic issues. And if you were following the election, and of course, even now, it's always about healthcare. So let's look at some of the things that are driving healthcare and some of the history of healthcare financing that led to what we're dealing with now. And how is it paid for? How do we get our pay? How, if a patient comes into the hospital, how they come without having to go home with bills. So who pays for it? And if people don't have insurance, who pays for that? And what are some of the economic issues that affect us in our practice? Okay, so some of the key historical highlights about insurance actually dated back to 1847, but I'm sure if you keep going back you'll see. But according to our textbook, it started with 1847, where during the Massachusetts there was Massachusetts Health Insurance of Boston that offers group policy. Then in the 1950s, the employee benefit packages was then offered. But in between that, the insurance plan, like in the 1861, in the 1990s, there were individual disability insurance. They had insurance plan that is available during the Civil War. In the 1920s, they had group health coverages for teachers in Dallas and Texas. In 1932, Blue Cross Blue Shield insurance began. I'm sorry, I'm skipping around here. Okay, Blue Cross Blue Shield insurance, or well, Blue Cross as they are known then. In 1934, the hospital began to receive payment from this third party like Blue Cross, and people had prepaid health insurance plan to protect them when they're in the hospital. And this was during the Depression. In 1945, the Blue Cross was actually capturing some of the monies that are being paid to the hospitals. In 1946, California Physician Services started getting payment through Blue Shield. And then in the 1950s, the employee benefit. So, and this is what we know now, if you work for a hospital, the first thing you should want to know is, their benefits, especially, health insurance and dental and all that. So when you work for an employer, they will offer you that as a way to attract qualified workers. And then in those during the 1950s, there was progression with disability programs, Social Security. In 1965, Medicaid, Medicare programs was created to help with aging Americans and, of course, Americans that are disabled. In 1977, the HCFA managed Medicaid and Medicare separately. They moved it away from the Social Security Administration. And then in the 1980s and 90s, managed care began to emerge. And we'll talk more a little bit about managed care. In 1983, hospitals started diagnoses to answer CMS under the DRG system. And we'll talk more about the DRG system because that's very important in the sense that if somebody goes to the hospital, they pay according to their sickness. And then in 2001 to 2003, CMS was created, and their job is to manage Medicaid and Medicare. In 2003, they had the prescription plan and this expansion in the Medicare, and that includes with prescription drug benefits. And then in 2006, they had Blue Cross Blue Shield that covers a lot of Americans. But of course, it's a third-party payer. Talk more about what does that even mean. And they enacted the pay for performance for reimbursement. In 2010, which is where I'm sure you guys were aware during the Obama administration when this was going on in the nation, the argument was, how do we protect people that don't have insurance, either due to they lost their job or something. So Obamacare was an attempt to bring socialized medicine to United States. It worked, but it's not 100%. It didn't work. So for instance, you have other countries like France, Canada, Great Britain. They have, it's not Obamacare, but they have similar, where as long as you're a citizen of that country, you will get seen in the hospital or by a doctor, whether you have insurance or not. So there's there's no insurance. The federal government of those countries will cover care as long as you're a citizen. So you see that in other, like France, Canada, Great Britain. So America tried to copy that, didn't work. It didn't work because of many things. We're going to look at why it didn't work. But it's, it's not something that you can easily come in. I mean, as we go on, hopefully by the time maybe 10, 20 years from now, it will become like that. And it's shifting a little bit that way, especially now that the Democrats are back into the Congress. Hopefully they will pass that. And why am I saying hopefully? Well, let's look at why. Okay, so one of the history with healthcare financing, that it's the physician used to drive it, not anymore. Physicians are used to be the primary decision makers. They control access to healthcare services. They decide what test, what procedure, how to run their patients. Not anymore. As managed care and DRG and all that is not are now in effect. Physicians that are no longer in control of, these entities will actually tell them what to do and how to run their patients. Some doctors don't like it, but it's, the history. So when they were doing this, they didn't provide the best of care. It's mostly like how much money can they make. So they order like tons of tests because they make money from that. Another thing that is in healthcare financing is technology. So technology is increasing, and that also costs money. So if you're going to have expensive technology, somebody has to pay for it, right? The medicine is becoming more sophisticated, like artificial intelligence. All those things cost money. So the fee-for-service payments, economic incentives contributed to this increase in cost. So the doctors before will decide how much they want to charge for, let's say somebody comes for pneumonia, they can charge $50,000 when it means the cost actually is like 10,000. So those things contributed to increase in healthcare costs. So the federal government stepped in, and of course, the consumers also complained. And so hence the change in healthcare financing. So one of the things I want you guys to be aware of, these terminologies, that the fee for service is different from the DRG. So with the fee for service, it's the doctors make the decision, and it's actually known as the retrospective payment system. They retrospectively bill for care. So let's say a patient comes for pneumonia, they would not bill for the care they rendered for that patient. Of course, they may end up adding POC to it, right? They may add, instead of running just ordering like 3 tests, they may end up ordering 10 tests, because somebody has to pay for their Mercedes Benz and their houses and their, lifestyle. So federal government stepped in and they formed the DRG. The DRG is diagnostic related groups, and this is a common reimbursement for healthcare now, and it's based on predetermined price for diagnosis. So if somebody comes in with pneumonia, there's already predetermined price that if you're coming in for pneumonia, we will pay you $3,000, right? I'm just making up the number. And that $3,000 is for you to do whatever. You can order 60,000 tests, we don't care. That $3,000 is all you're getting. So it forces healthcare providers to become more, to not order too many tests, because they're trying to save money, and they want to get this patient out of the hospital as fast as possible, because that $3,000 is not going to cover everything if they go over. So that's where DRG comes in. And so each diagnosis is assigned to a diagnostic grouping, and the payment to the hospital is based on that DRG. If the hospital exceed that money, let's say 3,000, and they exceed it, nobody, they will get paid. They will have to eat that cost. So hospitals were forced to now start being cost conscious and force their physicians to order less testing, right? Reduce the length of stay. Nowadays, instead of acute care, we want everybody to be taken care of in the community, so that the money that is being charged for that daily care in the hospital is minimized. So that's where the DRG comes in. So if you look at this chart, it's kind of like, it kind of shows you a little bit that increase in health expenditures. For the 1965 was like just 202. And then by 2016, the same, like I said, taking care of the same patient, it went up to 10,000. So Medicare stepped in. Medicare is a federal CMS, Central Medicare of Medicaid, stepped in to move to prospective. Remember, we used to be in retrospective. Now we're in prospective payment, which is DRG. So they joined in demanding that hospitals should eat the cost if they go over, right? Even if they justify it, doesn't matter. You're getting 3,000, that's all you're going to get. So if you want to go up to 10,000, that's good. But we're not paying that 7,000. You have to eat it up. So hospitals, to have good business, they have to meet that 3,000. So managed care decided, if people that are under Medicaid, Medicare. So if you think about Medicaid, it's for poor people, poorer, people that have to prove true income that they're in poverty. And then Medicare is for older Americans, but it also can be for Americans that are in disability, like people that are in dialysis or, that have chronic illnesses. So managed care decided, okay, everybody else that falls outside of that poverty level for Medicaid and for Medicare, they will provide for. So HMOs were formed, and part of HMO, you have PPOs, you have the point of service plans. And their job is the same thing that Medicaid, Medicare is doing, but differently. So for instance, with the PPOs, they cover their individuals. They may, the members have to select physicians, but they pay less for the physicians and the facilities if the physician is on the plan, and they may not pay for preventative care. So if you have PPO, you have to make sure that your doctor is within the plan, because that's how they reimburse. The managed care will reimburse them that way. For HMOs, it covers, but the member has to pay a premium, and there's always a co-payment, and they must select a primary care physician that the HMO must approve. If you go outside of that, they will say no, they're not paying. And that primary care will have to refer. So if your primary care is a GYN for women, and you want to go for cardiac, you can't just walk into a cardiologist. Your GYN has to approve it. And anything that is outside of the network of the HMO must be pre-approved, and before the person can get payment. So with HMO, they may refuse to pay for those services that is not within their plan. And one of the things that it makes them different from previous is that they actually encourages you to get preventative care. And you know that if you get preventative care, chances that you may not develop chronic illnesses. Oh, sorry again, and then you have the point of service, which can be by HMO or fee for service. Remember, fee for service is like you have deductible. For fee for service, you have deductible, you have co-payment, but you're allowed to choose physicians or specialists without anybody telling you, you have to be within the plan. The fee for service usually will cover reasonable or customary charges for things, for services, and they may not pay for preventative service, unlike the HMOs. So for point of service, it's offered by HMO or fee for service. And there again, point of service allows the members to use providers outside of the network, but they ask for higher premiums and they ask for co-payments for their services. So I want you to know the difference between all these types of managed care. Okay, let's see. So if you look at this question, in 1983, there's a revolution in health insurance, reimbursement that formed the primary method of reimbursement in today's health care system. And it's due because of two. There's rapidly rising healthcare costs. Because physicians were overcharging and hospitals were having fun, healthcare costs went from 202 to 10,000. So federal government stepped in to manage it. So that's the answer, number 2. Okay. So how about uninsured and underinsured? And I think this is where the argument with Obamacare started, that if people are uninsured or underinsured, it's not that they won't be seen. They will be seen, but who eats the costs, right? Who eats the leftovers? So let's say they're underinsured. The insurance company says, I'll only pay $5, right? But the charge costs $200. Who's gonna pay for that $195? So Obamacare came into existence. We'll talk more about Obamacare, but it's usually that the underinsured or uninsured, they lack access to care. There are many people in this country that are working, but they can't afford insurance, or they're working, they don't have an employer, so they don't have that employee benefit. So it's either, should I pay mortgage or rent, or should I pay for healthcare? Usually it's like, if you think of Maslow, I will pay for my resident, right? So I can have no homeless, even if I'm having chest pain and all that. So most of them, what they will do, they will access emergency room. They will use emergency room as their primary care provider. And that costs a lot of, it's very expensive. So it's kind of, it's called cost shifting. You're shifting that excess cost to the people that now have insurance. And again, that pushes the insurance premiums and payments up. So if you have insurance, you're actually paying for somebody that doesn't have insurance. So, and that's why Obamacare came into existence. So with Obamacare, it's supposed to help to bridge that gap for people that are underinsured or not insured. And you can never say, you know, I was having an argument with somebody and I decided to walk away because there's no way I could win that argument. They're saying that if somebody is illegal, they shouldn't have they shouldn't go to the hospital, they shouldn't access the hospital, and it shouldn't be paid, which is what Obamacare is. Affordable care is that it's helping people to be able to afford, whether, you know, I mean, they have to be US citizens and the legal residents. But let's say they're not US citizens and they're not legal residents, they have to still access. If somebody is having chest pain, they're not going to say, I'm going to sit in my, well, some of them do it, but some people will access emergency room, and guess what? They're going to still have cost shifting because they're not going to not be seen. So they will be seen, they will be treated, but they can't pay. So who's going to pay for it? The cost is going to shift to people that have insurance. So with affordable care, it's supposed to provide affordable health insurance. Of course, it has its benefits and pros and cons, which everything has that. But it helps to address some of that issue where people like part-timers or children that have outgrown their parents' insurance, like a child that is 23, they will kick them out of the insurance, or a child that ages to 21 will be kicked out of their parents' insurance, and then they're on their own. So what this affordable care is, what it's to bridge that gap so that everybody gets health insurance. Yes, you're paying, but you pay according to your income. And it helps with the cost shifting so that people that do have insurance, that their cost will not be too much, it will lessen. So Medicare also decided, well, if this affordable care, which actually I appreciate because I have a 23-year-old that doesn't even know what health insurance, what does that mean, right? Because, he's still young and healthy and all that. But he keeps him under my insurance until he's 26 years old. By then, hopefully he will get a job, right? And finish school and all that. So it helps to help that gap. And the Medicare jumped in. Medicare said they will no longer pay hospitals to treat things that doesn't make sense, like sentinel events, like a pneumonia or fall or skin infection. If you go into the hospital, you should come out, right? You should come out the way you went in. So hospitals are beginning to become more quality, like what we discussed in class today about quality improvement. They're now looking at outcomes, quality outcomes. We need to have our patients, we need to give them good quality care so that we get paid and we keep them out of the hospital, because if they come back within 30 days, we will not get paid. So hospitals are really, and that's when you start working, you're going to see that everybody will be beating into your head about quality, quality, quality. So the PPACA, affordable care, or Obamacare, whatever you call it, it could be a plus for us. And actually, I think it's a plus for my specialty, especially with women. We don't say you're underinsured or no insurance, so you can't have a baby. If a baby is coming, a baby is coming. But we want to get paid for that service. So this is very important. So again, please review Obamacare. There's so many pros and cons to it, but look at both sides. That's part of being a student, is that you're not only looking at one side, you're looking at what is it good for and what's the bad part about it. So if you look at this question, what is one rationale in support of healthcare reform? Well, the rationale is number 2, that uninsured population will generate uncompensated care costs that lead to a process that I talked about, cost shifting. So whether we like it or not, people that are uninsured, underinsured, or even no insurance, right, that not even exist, like illegal aliens, they will continue to access healthcare. They're human beings, so it's acceptable. However, they're not paying for it, So the cost will shift to middle class, like nurses, student nurses, anybody working that has insurance will be absorbing that cost. And hence, the healthcare cost will keep rising. So importance of trying to bridge that gap to bring everybody in. So the answer is 2. So private insurance. So who pays for all this here? We talked about CMS, we talked about Obamacare, which tried to be a socialized medicine that in France and Canada and Great Britain had, but it didn't work. I'm sure, but I'm keeping my fingers crossed that it will work one day, right? But who else are the other people paying? So we already mentioned HMOs, right? Private insurance falls on the HMO fall under that. They're the largest percentage of coverage for healthcare in the United States. And usually you get these through your employer. And that's actually one of the things I look at when I go for interviews for a job. I ask them what type of, well, not the first interview, but subsequent interviews. I want to know what type of insurance. Would they cover me? Would they cover my family? Will I be able to afford it? So those are the things you should be looking for when you're picking your employer, because it comes from the employer. And then you have the public insurance. We talked about this already, right? Medicare and Medicaid. Medicare is the largest health insurance program in the United States, and it's based on disability and age and need. So usually it's for 65 years and older, right? However, if somebody is disabled and they haven't hit that 65, they can still be able to to be covered under Medicare. So it's usually federal government. It's under federal government. You have different parts of it. You have Medicare Part A that covers for inpatient and for nursing homes, and they even cover for home health. And then you have the Part B and Part C. So there are different parts of it. Some of it, the Part B will cover like outpatient services and, if you go to the doctor kind of thing. And then they added the prescription part of it, and that covers for prescription. For Medicaid, you have, it's similar to Medicare, except age again. It's usually for low-income households with children. I know in New York, we have CHIP. CHIP is for children. So if you have children in New York that their parents don't have insurance, that child has insurance because they have children health insurance. And I'm sure the states probably have that, but I know for New York, we have that, and that covers children. And then you have, for people that less than 65, but they're low income, that would also cover them. I know in OB, we cover women, doesn't matter if they're American citizens or not, we don't care. As long as you're pregnant, we will be covered. So that's the public insurance. So all this insurance, again, hospitals depend on them. And if you think about some of the things we do it for them. All the quality measures, all the patient satisfaction, all those things, we're doing it for these payers because they look at it before they can reimburse. So there are other payment methods to control cost and quality. We mentioned some of it, like with Medicaid, Medicare, that you have to make sure your patient, the way they go in is the way they come out. But let's look at the pay for performance. They look at the hospitals will dump their data. They collect data all year round and they dump it into a database that compares it to other hospitals. And they actually will be paid according to how well they do. So are they great with trauma, with ventilator-associated infections, with regular infections? So many hospitals are working on those quality measures because it determines how they are reimbursed. And the never events actually came about with, it was the time where people, if you go into the hospital, you will not come out. People will actually cry because they know you're going to die there. So Medicare decided they will not pay for any never events. Never events are medical errors that cause somebody to die, almost die. Or so egregious, meaning so serious that it could have caused the patient to die. So for instance, switching babies, giving the wrong baby to the wrong mother, from my specialty. But I can think of other things from other specialties, like cutting off the wrong leg in OR as opposed to cut off the right as opposed to the left. So again, it's a way to get rid of errors and encourage hospitals to be more diligent when they're providing care for patients. The other one is value-based purchasing. Value-based purchasing is actually a CMS requirement. Again, I keep calling CMS because they're the leaders in payment, Medicare. So they reimburse for inpatient hospitals to provide quality care so that patients will be satisfied. So if you're in the hospital, if you work in a hospital, you hear them talk about HCAHPS, HCAHPS, HCAHPS. HCAHPS is actually measuring patient satisfaction. Is the patient happy? And that changes the way we practice, because now we practice like that you work in if you go to Walmart, you go into one, they will say, welcome to Walmart. I'm like, yeah, that's what we do in the hospital. We want people to be happy. So we do extra things. We make sure their beds are clean, room is clean, answer the call light. We're not rude to them. Why? Because these patients are going to grade us. It's like the grade that you guys, not grading, but the survey that you guys do for your professors at the end of the class. The patients will grade us at the end of their stay. And they use that grading to determine, to pay, if Medicare wants to pay the hospital or not. So that's where value-based purchasing comes from. So importance of everything you learn in this class, how to use communication skills, how to be a team part of a team member, that, how to collect data, how to do quality improvement, all those things. And because the communication is so important when it comes to HCAHPS. And also pain management is another one that they kind of like monitor. And then to reduce readmissions, it's a part of Obamacare. And in that, I talked a little bit about it before, but if a patient goes home and they come back on the 29th day, the hospital will not get money. The hospitals CMS will withhold that money, because patients are supposed to go home and stay home. They're not supposed to come back within a month. So that helps with readmission, especially with some of the chronic illnesses out there like pneumonia and COPD and all that. So if you go to hospitals, and I think we talked about this, or case managers, they step in and their job is actually to keep this patient home for 30 days. After 30 days, they can come back, right? So these nurses will follow these patients home. They will call them, make sure they're taking their medications, they're going to therapy, they're doing what they're supposed to do. That way they're not readmitted for what they were treated before going home. Because if they come back, no pay. So it's so many things that are happening that all that is, always think about, it's all about how do we reduce money. So for instance, accountable care organizations, medical home models, all those things are part of case management, a way to manage population. So it's kind of like population care management and case management to make sure that patients stay home, because staying home is cheaper, again, you're looking at money, than coming back to hospitals. And then if they come back to the hospital, can the hospital get paid? Did that patient stay home for that 30 days they were supposed to stay home? Okay, so all these things, again, remember, it's just incentive to, increase efficiency and cost effectiveness. You now have free standing clinics, outpatient clinics. You have care, like I mentioned, is now moving from acute care to community-based. So home health is a big deal now. There is more emphasis on preventative care. I actually have my insurance pays me if I go to gym. I'm like, wow, So there are so many things that are happening to prevent chronic illness from even happening. to begin with. And that helps with the federal and state budgeting and all the fight in Congress about, money, how much is allocated for instance, with COVID, what is going on with COVID, how much is allocated for hospitals, for PPE, for preventative care, for vaccine and all that. It ties all back to efficiency and cost effectiveness. So what does that have to do with us? Well, a lot. First of all, we want a paycheck, right? If you don't want your paycheck, send them to me. But if we don't get paid in the hospital, they won't pay us. They won't have money to hire nurses. So it's importance of delivering high quality care for low cost, right? Give the best care, but use the minimum cost to provide that care. And be cost efficient, be cost conscious when you're doing things. It helps to, again, and the class today, I think we talked about STEEP, IOM, CHASM, providing safe, timely, efficient, equitable, effective, and patient-centered care. That's what is that we're moving towards. So it's going from treating the illness to preventing it, moving away from acute care to home-based care, that hospitals are no longer needed except for very sick patients, like ICU type of patients or deliveries. Even with deliveries, they want you out of the hospital within 2 days. Moving away from fee-for-service, which is very expensive, to more of value-driven payment. So if you give good care, we'll pay you. So it's, again, it's more, and it's opening up opportunities for us as nurses. It's opening roles for case management, using technology like telehealth to deliver care, and teaching patients. Patients can actually help us, right? They should practice good health behavior, like putting on their mask, especially when with COVID, hand wash, use the internet to learn about how to take care of themselves. Look at know what lifestyle that is good, such as cutting down on alcohol and drug abuse and more exercise, and reviewing their healthcare bill. So when they get a healthcare bill, they should look at it to make sure that what's in there is what's supposed to be there. And knowing that using the emergency room is not the way to go. Emergency room is actually bad for patients. I encourage patients, if you can wait it out, wait till your doctor's office open, right? First, it's cheaper to the doctor know you than emergency room. So that's where we come in, and that's what when you start practicing, this is what you're going to see. And many nurses enjoy this because they know the rationale behind it, so less burnout. But if you don't know the rationale why some policies are there, or they're asking you to collect this data and do that, it will become very annoying. So now that you know, hopefully it will help you when you start practicing why some of the practices that they're asking for you, that is tied to payments. Okay, so that's the end of the lecture, and I will see you guys in class.